So we continue our theoretical course dedicated to the introduction to implantology. Let me remind you, we're doing all this in order to learn how to properly design templates in the RealGuide software. But there's no way around the theoretical foundation here. Please bear with me. Let's imagine we're second, third, or even fourth year students. I don't recall exactly when this starts. In front of us is an implant inserted into bone. This is a schematic image, or more precisely, a diagram. So what do we see here? We see that the implant has been placed into the bone, and it is held there by its threads. In other words, it is held there mechanically. And since the bone bed, as I mentioned earlier, is narrower, in other words, has a smaller diameter than the implant itself, these threads break the bone trabeculum. As a result, primary stability of the implant is achieved. Let me remind you, this is the kind of stability that is provided by the threads. You're probably already tired of hearing this, right? The fact that I keep repeating this several times, it's because it's very important to understand the principle of implantation itself. So initially, the implant is secured by the threads. That's it. Remember that. But what happens next? People whom I hope none of you have ever been injured, but if someone has ever broken something, then, you know, or maybe you've heard about the whole process that happens afterwards. Implantation, like any other surgical intervention, especially when it involves bone the body perceives as a trauma, our body has clear instructions for what to do in various situations, or rather what it does in different circumstances. So when the bone is damaged and accordingly a bone trabecula breaks, the body perceives this as a bone fracture, you could say. And the body's self-healing strategy here is that it consolidates the bone fragments, resorbs them, and accordingly restructures the bone tissue in such a way, in other words, it regenerates and restores it anew. That's why after you place an implant, over time, the process of bone tissue remodeling begins around the implant. And this bone tissue that surrounds the implant becomes significantly softened. If we really get into the details, there are cells called osteoclasts and osteoblasts. Osteoclasts resorb bone tissue, while osteoblasts, on the contrary, produce it. All of this, it's not a sequential process. In other words, it all happens simultaneously. And the question is, like on a scale, which is greater? Osteowell, which process predominates, osteoclasts or osteoblasts? But they work together during the same process, during the same period of time, excuse me. Why is this important for us? Because when we place an implant, by the way, the picture here actually shows a torque wrench, and it's shown here for a reason, because when we place an implant into the bone offers some resistance, and a value called torque appears. Torque is a physical quantity that is measured, I believe, in newtons divided by square meter. Well, we don't have any square meters here. In implantology, I think we use square centimeters. And this is the value that is the force that needs to be applied to the implant in order to make it turn. Well, please don't throw rotten tomatoes at me. This is a very simple and primitive explanation. But the main thing is for you to understand what torque is. So the extent to which the bone, the strength with which the bone connects to, or rather resists the implant, is called torque. Accordingly, the surgeon uses a torque wrench if they are placing implants manually, and this torque wrench shows the amount of resistance the surgeon applies to the instrument in order to screw in the implant. Torque affects the primary stability of the implant and consequently influences the possibility of immediate or early loading of the implant in the future. But let's take it step by step. So why did I show this torque wrench here? Because let's say initially we installed the implant with a force applied to it equal to 40 newtons per centimeter squared. And as I already mentioned, after the surgery, after the implant is placed, the process of bone tissue remodeling begins, and accordingly, this bone tissue softens. That is, it becomes less dense, it undergoes lysis, if you will. And the force required to rotate the implant, amount you need to apply becomes less, meaning you need to use less force. This means that the process, let's say, if this process, specifically the loading on the implant, is done incorrectly, it can lead to complications because this process of bone remodeling must be taken into account. But if the bone is remodeling, you might ask, what happens next? What happens next is what is called secondary osseointegration. And implants are not just a metal pin that is inserted into the bone and stays there forever only because of the thread. Rather, you could say it's a unique phenomenon, which I believe was discovered by Bronnemark in the 1950s, and it is associated with what is called osseointegration. If you've ever held an implant in your hands and seen it, so to speak, in real life, you might have noticed that it is matte and rough. Well, this roughness is achieved thanks to micropores on the surface of the implant, as you can see, and these micropores are not there by accident. These micropores are specifically needed so that osteoblasts and osteogenic cells can use their processes to connect with these pores and grow into them. This effect is called, in fact, osseointegration. And as a result, the implant becomes one with the bone, so that the entire structure is indivisible. If we look at how this appears, let's say, under macro magnification, it looks something like this. That is, we can see that the processes of bone cells penetrate into these micropores of the implant, binding together with it as one. So it's important to understand that the implant is held in place not only by its mechanical retention, that is, by the mechanical properties of its threads, but it also fuses together with the bone and becomes, in a sense, an indivisible substance with it. Based on this, I'll show you an interesting table, or rather, a graph where the vertical axis represents stability expressed as a percentage, and the horizontal axis shows the first week, second, third, fourth, fifth, sixth, seventh, eighth, and so on. So if you pay attention, just as I mentioned earlier here, two lines are shown representing the primary and secondary stability of the implant. The blue linear, whatever color it is, I can't quite see here, shows the primary stability of the implant, and we can see that it decreases. That is, it was at 175, 50, 25, and so on and so forth. In other words, the primary stability of the implant decreases because there is lysis of the fractured trabeculi, lysis of the bone tissue around the implant after the trauma we caused during implantation. But bone tissue remodeling takes place. New osteogenic cells are formed. They bind together with the micropores of the implants, and osseointegration of the implants occurs. That is, the secondary stability of the implant increases. Once again, the primary stability of the implant is related to the thread, to its mechanical properties like a screw. And the secondary stability of the implant is the binding of bone cells together with the implant at the cellular level, that is at the micro level. You've probably already fallen asleep by now. Actually wake up, because here comes some important information that we need for practical purposes. You can see here another line, which is called total stability. This is the result of these two graphs, and as we can clearly see, we observe this kind of noticeable dip, which actually reaches its lowest point, or rather its very bottom, in the 4th week. This means that there is a period indicated for primary, or rather for loading, and there is a period when it's better not to load the implants. So, for example, if we load the implant during, say, the 1st week, this is called immediate loading, and that's okay. Everything is fine because the primary stability of the implants is present. And the most dangerous time for loading, as we can see, is the 3rd, 4th, and 5th weeks after implantation. Because on the one hand, osteoclastic processes are already underway, associated with the lysis of bone tissue, in other words, the resorption of bone tissue around the implant, but the secondary stability is not yet strong enough. That is, the implant is not 100% integrated. In fact, as we can see, by this time it is integrated by only about 25%. Therefore, it is not a very good idea to load the implant, or rather to load the implants from the 3rd to the 4th or 5th week after implantation. This is just a note about timing, because anything can happen in life. For example, you placed the implants but weren't able to make the prosthesis, crowns, and so on in time. Someone went on vacation, got sick, or there were other reasons, and you decide, no, that's it, I'll just finish it, basically. But now you understand that it's not always justified, not always necessary, and not always the right thing to do. So if you miss that 1st week window, it's better to wait until the body does its job, the bone tissue does its part, and everything will be fine. Now let's talk a bit about the placement of implants. Here we have screenshots from the RealGuide software, and you can see that there are several lines. Here we have this green line, which represents the bone. This is a frontal section, again, of the lower jaw. Well, the implant is marked in purple, obviously. Pink here is the superstructure, or say the abutment teeth, doesn't really matter. Here we have pink, or this orange one, I'm not sure. Well, let's call it orange or ginger. Okay, the ginger color represents the mucosa, the contour of the mucosa, and accordingly white is the crown. It is very important to position implants correctly and to place them according to the bone, because in fact that is what you are doing. Your task, the main goal of all surgical guides, is to transfer what you have planned into reality, into the oral cavity. And a good surgical guide is one that transfers everything from the planned position into reality. Even if you modeled everything terribly, at least from a surgical standpoint, that's why our task is, you could say, to kill 2 birds with 1 stone. That is, to position the implant well, to plan it properly, and to make the guide in such a way that this position is accurately transferred into reality. So let's take a closer look at this kind of implant placement, specifically at the level of the bone tissue. What's bad about this approach? Actually, there are 2 main drawbacks here. By the way, in the early days of implantology, this is pretty much how implants were placed. There was even a recommendation to place them flush with the bone, and supposedly everything would be fine, and so on and so forth. But what does this lead? The first issue is that the cervical area of the implant, as you can see, comes into contact with the cortical layer. If you watch the video I mentioned, the one about the cortical layer, you'll notice and can note for yourself that the blood supply to the cortical layer is not as good as that of the spongy bone. And most often it is with this positioning of implants that cervical resorption occurs. In other words, this is the process in which the bone recedes, you could say. That is, it undergoes lysis, it resorbs around the implant, around the neck of the implant, and this is a long-term postoperative complication that needs to be addressed. If nothing is done about this, then the implant may eventually be lost. In other words, it will disintegrate. This is the first issue, which is especially problematic and concerning, and which in fact directly results from this particular kind of implant positioning, as you can see. The second point is that from an orthopedic perspective, the result is not very functional and not very aesthetic, because we can see that the implant's superstructure, specifically the abutment, protrudes above the level of the mucosa. And if we place a crown on this superstructure, as shown here, of course, this is all schematics, it's clear that the crown will rise above the level of the mucosa and will appear to be floating. In other words, there will be no emergence profile for the crown. There will also be no gingival cuff. Food will get trapped in this area, and where there is food, there is chronic inflammation. And where there is chronic inflammation, there is bone resorption, and then the whole cycle starts all over again. So it's the same complications all over again. And honestly, from an aesthetic point of view, it doesn't look very good. When you have a smooth mucosa and a crown seems to have just appeared out of nowhere above it, in reality, on natural teeth, there is an emergence profile. That is, our tooth, the crown of the tooth, let's say, emerges from the gum. With this kind of placement, you can't achieve that. Let's look at another option, a slightly different one. We've placed the implant a little deeper. And what does this lead to? Or rather, let's analyze it now. We can see that the implant is placed a bit deeper, and now the entire implant is within the spongy bone layer, and this safety zone is preserved about 1 millimeter from the neck of the implant. And in general, try to place implants, but again, you're free to do as you wish. Let me rephrase a bit. We try to place implants with a margin at least 1 millimeter from the edge of the cortical layer, the cortical plate, because if you don't do this, the blood supply will be compromised, and accordingly, there is a risk of resorption, cervical resorption, which we discussed on the previous slide. Accordingly, here the implant is completely embedded in the spongy bone layer, and in this case, its blood supply will be adequate. That's the first point. And the second point is that the superstructure is, you could say, located beneath the gum. Yes, as surgeons, we will have to create, let's say, a bone collar that is a space in the bone for this superstructure so that it can fit in there, because as you can see, it is wider than the implant itself. But nevertheless, it's worth it, believe me. Here's another example. The patient has a rather thin gum biotype, but even so, this positioning is much better, because with this placement, it becomes possible to make the crown in such a way that a gingival collar can form. In other words, the crown will appear as if it emerges from the gum, making it more aesthetic. Additionally, the gum in the cervical area of the crown will naturally adhere to the crown itself, forming a protective seal, and thereby effectively help to prevent food particles and debris from getting in there. As we mentioned in the first case, this is generally considered to be the most preferred and recommended way to position it. This placement of implants is called subcrestal. Not crystal as in the word crystal, but crest, because in Latin it refers to the cortical layer. So sub means under the cortical layer. That's why implants are most often positioned this way. Let's consider another option. This, you could say, is an extreme case. This is an implant placed too deep. What's the catch here? Obviously, most likely you won't have any problems with nutrition. Most likely there won't be any issues with integration either. Although, of course, nothing is guaranteed, especially in surgery. But here, a problem arises with prosthetics, because you end up with a very tall superstructure. And in fact, this distance from the edge of the crown to the implant platform becomes greater than the implant itself. Ideally, it should actually be the other way around. Of course, there are compromise options, but we still aim for the implant to be longer than the crown portion. It's all quite simple. Let's imagine that this is my implant, and the root well, the implant itself, is longer than the superstructure and the crown itself. That's why during lateral movements, that is side-to-side movements, the lever here is much shorter. But let's imagine that this lever is actually very large. In fact, it's quite significant. And we can see that much less force is needed to shake up this whole system. That's why such a setup isn't exactly ideal, as you can see, on the one hand. And you also need to think here, in blue you can see my artwork. I wanted to show that a pretty simple problem can arise when, for example, your supplier just doesn't have such long superstructures on the market, because sometimes the implant is placed so deep that there simply aren't abutments or multi-units that are tall enough. This can also become a problem. So to sum up everything we've discussed so far, it's better to leave a couple of millimeters from the edge of the cortical plate. But of course, you also need to take the gingival biotype into account. In other words, placing the implant flush with the bone isn't ideal, and placing the implant too deep isn't great either in some cases. And let's move on. Here, I'd like to talk not about single implants, but about implants that are part of, let's say, part of a prosthetic structure. In this case, we plan the prosthesis using the all-on-4 conceptor. Obviously, the implant channels are marked in yellow. And here they are completely parallel. That is, you can see that the implants are parallel to each other. More precisely, it's not even the implants themselves, but the exits of the channels that are parallel, because later these channel exits are transferred to multi-units. So the main point here is that even from a basic school physics course, it's clear that the best support, specifically if the force vector is perpendicular, that is going from top to bottom, the best support is at 90 degrees when we are doing something, or more precisely when we are holding something. That's why implants are positioned as parallel as possible. Sometimes there's a slight deviation of a few degrees, but that's not critical. In general, the more parallel they are, the better. That's the first point. And the second point is that it's not enough to simply place the implants. It is also necessary to think about the future design. And after placing the implants, surgeons hand the patient over to prosthodontists and technicians, and then they rack their brains over how to actually fit the prosthesis. It can simply happen, like in this case, that it becomes extremely difficult to fit the prosthetic structure. Imagine you have several support points that are angled in different directions, and you somehow have to manage to fit everything so that it all sits properly. And of course, in this case, the load will be distributed less effectively because the force vectors will also be going in different directions. So to sum up, the best approach is to place the implants, or rather, not even the implants themselves, but the abutment exits, meaning the projection of the abutment exits as parallel to each other as possible. First of all, your orthopedist will thank you very much. Secondly, it is more aesthetically pleasing. And thirdly, it extends the life of the prosthesis, extends the life of the structure because the load is distributed correctly. And it also extends the lifespan of the implants themselves. And now, I'm not sure if I'll have time, but let's talk about procedures called osteoplastic surgeries. And from the name, you can understand that an osteoplastic surgery is a procedure aimed at some kind of bone reconstruction. Most often, we encounter myocardial surgery, but more commonly, we deal with the lack of bone, meaning there isn't much bone present. And in most cases, we resort to procedures involving one type or another of bone tissue augmentation. Here on your slide, you see an open sinus lift, which we are going to talk about now. What does this mean? Here too, we have a schematic frontal section of the maxillary sinus. And we can see here, this is the sinus itself. Everything is quite schematic, as I already mentioned. And accordingly, we don't have enough bone to place the implant, because the implant must be surrounded by bone, or let's say a bone graft. So if we encounter such a situation, we need to do something about it. By the way, the amount of bone that was present there originally and still remains before the surgery in this particular case with an open sinus lift surgical procedure is what is essentially referred to as native bone. In other words, the bone that is naturally there. This is a term that refers to the bone that exists before the surgery, and sometimes the amount of native bone, specifically the amount present, is what determines the indication for a particular type of surgery. For example, if you are planning to place an implant, say 8 millimeters in length, but the amount of native bone is 3 millimeters or less, then this is an indication for an open sinus lift, which we will now discuss. If, for example, you again need to place an 8 millimeter implant, but the patient has, say, 6 millimeters of native bone, then you realize that it makes no sense to perform an open sinus lift just for those extra 2 millimeters. You can do a closed sinus lift instead. So this is a brief overview, you could say, of open sinus lifting, but we'll go over open sinus lifting and bone osteoplastic procedures in more detail in the next video. Thank you very much for watching. Keep scrolling and keep learning. See you next time.